All right, once to do that, we're going to talk about permanent impairment in psychiatry for the next 45 minutes. And as James said, I've been doing this since about 2010. It's been about 4 or 5 years that I've been doing this. And one of the things you guys need to understand about permanent impairment assessment or medical legal assessments is that in our psychiatric training, we never really get trained for this in particular. We get trained about clinical issues and management and treatment, but we never get trained for work cover assessments, medical legal assessments, permanent impairment assessments. It's something you tend to learn on the job. So the things that we are going to try and cover today, number one, is to get an understanding of the various definitions related to impairment, permanent impairment, disability, talk about some of the confusing aspects which may be there about these definitions, then talk about the principles that relate to permanent impairment, and I'll give you some examples over there as well. We're going to talk about the different impairment rating system. I'm just going to give you an overview about 3 or 4 impairment rating systems which we commonly tend to use. Talk about common errors in assessment and errors that I've seen during practice, errors that I've been close to doing or have done as well, or have made as well. And finally provide some case examples. As James said, we'll leave some time for discussion in the end for any questions that you may have. So that's the objectives for today. Now, for as long as the terms impairment and disability have been around, not medical legally, but clinically, they've been around for a lot longer, there's been a confusion in terms of the relationship between impairment and disability. And as we started getting into the medical legal field, that confusion is kind of heightened or exaggerated. So in simple terms, impairment is anything that's wrong with your body from a health perspective when you look at health. So anything that's wrong with your body, you don't have an arm, you have hallucinations, you're sick, all that is basically impairment. And when you look at disability, disability is what that impairment affects you, what it prevents you from doing socially, moving around, getting down the stairs, getting up the stairs, getting outside the house, working. All that is disability. So it seems fairly simple in that impairment generally can or cannot lead to disability. There are a lot of people around over there that have impairment. You may have pain in some areas, but you still carry on. You don't have a disability. It doesn't prevent you from doing your usual thing. When we come into the medical legal field, things become a little more complicated. From a psychiatric perspective, impairment is any loss or abnormality of psychological function. So low mood, poor concentration, poor sleep, lack of emotions, all those are impairments. When you get into disability, it's an inability to carry out an action or activity because of that impairment. So if you're not able to get outside the house, if you're not able to meet people, if you're not able to work, that is the disability. An impairment may or may not lead to disability. As I said, a disability always has to have an impairment present. Now, if that's not confusing enough, I'm sure you're aware that most of us, when we assess patients from a psychiatric perspective, we use the DSM system. That's a Diagnostic and Statistic Manual. That's the American system. And the DSM system is excellent. It's very good in how you assess patients, how you classify patients. So for each condition, for example, major depression, you have criteria, you have symptoms that need to be met and need to be present for a particular length of time to diagnose somebody with, say, depression. So the symptoms would be your low mood, your poor concentration, your anxiety, your sleep disturbances, appetite, and so forth. So that's the impairment. So there needs to be an impairment, definitely, for any psychiatric condition. The interesting thing that happens is that every psychiatric condition we look at, especially in the medical legal field, all of them, there is another catchphrase in the DSM diagnosis, that they need to have a significant effect on their social and occupational functioning, i.e., they need to have a disability. For all psychiatric conditions, if they need a DSM diagnosis, there needs to be an impairment and there needs to be a disability. What I'm trying to say is that for all practical purposes in the medical legal field, impairment is equal to disability. So when you hear about permanent impairment assessments, we're actually looking at disability assessments. For example, I'm going to talk about the PIRS scale, the Psychiatric Impairment Rating Scale. The Psychiatric Impairment Rating Scale doesn't assess as much of the patient's impairment or symptoms. It assesses the disability, whether they are able to travel or not, whether they're able to work or not, whether they're able to go out and engage socially or not. That is not assessing impairment. That actually is assessing disability. So whenever we talk about impairment in medical legal field, almost always we mean disability. That's a good confusing thing to start off with. I'll give you an example just to make that a bit clear. A 36-year-old gentleman comes in for a medical legal assessment for some kind of a workers' compensation claim. He presents with low mood, he presents with anxiety, his concentration has not been very good. So it's quite obvious he has impairment. It's very obvious that he has impairment. Now this person may or may not have a disability. This person with low mood, poor concentration and anxiety may still be working very well. This person with low mood and anxiety may still be engaging socially extremely very well. So if he does engage socially, he doesn't have a DSM diagnosis. If he does engage occupationally, he doesn't have a DSM diagnosis. If he doesn't, he then has a diagnosis. And only then, generally, you proceed to the level of impairment assessment. So he needs to have a disability. So if impairment wasn't confusing enough, we've got permanent impairment. And in our field, we generally tend to do a lot of permanent impairment assessments. And when we do permanent impairment assessments, they're generally based on 3 principles. The first principle is that the condition needs to be permanent. The condition needs to be present for the foreseeable future. We, as psychiatrists, do need to opine that this person is going to present with so-and-so symptoms for the foreseeable future. I'll talk a little bit more about that. Number 2, he or she needs to have received reasonable treatment. And we'll come around to what reasonable treatment would be. And number 3, there needs to be a level of stability. So you would expect that this person's symptoms, impairment, disability, whatever you call them, is not going to change much, again, for the foreseeable future. And now many of you may have, or some of you may have heard the term maximal medical improvement, MMI. So what is that MMI? It's a term used by the Americans in their guides, the AMA 4, 5, and 6, in that when a person has a symptom or an impairment and you have permanence, you have reasonable treatment received, and you have stability, the person is said to have reached a stage of maximal medical improvement. And that's generally the best point to assess permanent impairment. So, when we assess a patient for permanent impairment, we are essentially looking into the future and commenting on how long this person is going to be having the symptoms. All our decisions, whether it's permanent impairment, whether it's compensation, whether it's diagnosis, is based on one principle: balance of probabilities. If there are 100 eventual outcomes, more than 50 outcomes would be your opinion. More than likelihood that this person is going to have symptoms for the foreseeable future. He may not have those symptoms for the foreseeable future, but as you assess the patient on that day and the information that you have, you believe that this person will have symptoms for the foreseeable future. So how do we do that? How do we actually look at the future? How do we predict the future? How do we do the best? How do we best try and do that? The 2 most important aspects of predicting permanence is duration of symptoms, for how long the patient has had the symptoms, and the severity of the patient's symptoms or disability. So in terms of duration, I often get asked how long is long enough in terms of psychiatric symptoms. And you generally say 1 year. If the patient has had symptoms and impairment for a period of 1 year and things haven't changed much during that time, you can say that the person is likely to have symptoms for a fair length of time. Now that's individual to individual scenarios. It's not always 1 year. In some situations it can be more. The severity of symptoms and disability, how bad the patient presents with symptoms. Is he able to work? Is he able to get out? Is he able to do anything of that sort? So the severity of symptoms and disability is quite important. And finally, if these are not the things that conclude your assessment, you generally look at maintaining factors. So are there any other factors that is causing the person impairment that tends to change your opinion? So those things could be alcohol misuse. Those things could be ongoing work-related stressors. Those things could be ongoing social stressors. Those things could be ongoing pain. A lot of people that present in such conditions have chronic pain conditions or back pain or injuries that tend to be permanent, that tend to cause psychiatric symptoms that persist for a long length of time. So they could be maintaining factors. So that's talking about permanence. The second criteria that needs to be met is that the person needs to have had reasonable treatment. And what is that reasonable treatment? Generally, reasonable treatment for a psychiatric or physical condition involves a specialist intervention. Now, in psychiatry, there doesn't necessarily need to be a psychiatrist involved, but at least some other mental health professional involved, preferably a psychologist. I mean, ideally, you'd like to have a psychiatrist involved. But where there have been assessments without the involvement of psychologists or psychiatrists, and assessments have relied on GPs' understanding of impairment rating systems, there is a possibility or probability for errors. And I'll come around to that one. So there generally needs to be specialist intervention. There not only needs to be specialist intervention, there also needs to be enough of specialist intervention. I've often had situations where impairment ratings are given to patients saying that they've received reasonable treatment, and then reasonable treatment was seeing a psychiatrist on 2 occasions in the last 2 years. Because things had been going well, or because they didn't believe things had to be changed. But when you see the patient is actively depressed, their medications are not working, they could be better. So they haven't received reasonable treatment. How often they see their psychologist? Have they seen their psychologist? Have they been compliant with the sessions with their psychologist or psychiatrist? You often look at medications. Psychiatry is a field where we really look at medications in most situations, or try to look at medications in most situations. We try to give them psychological intervention, but often, especially in the medical legal scenarios, you do need medications to be used. So have medications been used? Have they been compliant with the medications that have been provided to them? How long have medications been used? Which medications have been used? What dose have they been used? Those are the things we tend to assess. Sometimes patients present with symptoms that require more invasive interventions. By invasive, I mean, or intensive or invasive, I mean hospital admissions. I mean things like electroconvulsive therapy, shock therapy, things like attendance at day programs. Now, that's a totally different field. That's not something that you can consider reasonable unless there is a die-hard situation that requires patients to be admitted into hospital. You cannot consider ECT a reasonable treatment. I've had situations where psychiatrists who've seen claimants have said, this patient has not reached a stage of stability because they haven't received appropriate treatment. And appropriate treatment in this case would be shock therapy, would be ECT. And if the person doesn't receive shock therapy or ECT, they cannot be assessed for permanent impairment. Now, you can't really force somebody to go into shock therapy to ECT. It's not a very civilized treatment as it appears on the face of it. It does work, but you can't really force everybody to receive that treatment. It requires consent. That takes me to the next point, which is treatment refusal. I'm sure most of you have had situations over here where you've had claimants or patients that refuse treatment. And what do we do in such situations? Can they be assessed for permanent impairment if they refuse treatment? It depends. It depends on the situation. My understanding of this is if they refuse medications, if they refuse biological treatments, there's not much you can do about it. We've recently had the GEPI guidelines, the guidelines to evaluation of permanent impairment, and I kind of looked at it to see if there's anything different. And all it says as well is, look, if a patient refuses treatment, you still assess the patient for permanent impairment. If everything else is met, you just make a note of the fact that the patient is refusing treatment. Making a note doesn't really change anything. It doesn't change permanent impairment. If a person is suffering and has been suffering for a while but has not received any treatment whatsoever, has not seen a GP, has not seen a psychologist, it tends to cast some doubt about the patient's presentation. So you'd expect them to receive some treatment. And what that sum is, it changes for every person. There's no set criteria that says this is enough as a treatment. So treatment refusal can be a complex situation. It can work both ways, where It sometimes is good for patients not to receive treatment. Sometimes it's not very good for patients not to receive treatment. I've had a couple of situations where patients that have claimed for permanent impairment have come in for the assessment, and they come and say, I don't need treatment. Why don't you need treatment? Because there's nothing wrong with me. Okay, but you're here for a permanent impairment assessment. And they say, yes, the amount of distress that I've faced because of X and Y situation, that's causing me a lot of distress. Okay, so do you think you need any treatment to manage that kind of stress situation? No, there's nothing wrong with me. It's just the situation that's causing that. You can imagine that that's not an easy situation to assess and then say, yes, this person has an impairment, and yes, this person has reached the stage of maximal medical improvement. Finally, of those three pillars, if you may call them, is stability. You're basically asking yourself, are things going to change with this person? So what do we look at? The duration of consistent symptoms. For as long as the patient has had consistent symptoms, and when I talk about that 1 year period where patient need to have that symptoms for 1 year, that's an arbitrary figure, but they need to have had symptoms consistently, whether too high, too low, or no symptoms. And once that happens for a period of 1 year, roughly, you can say that the patient has been stable. Have there been any changes, or do you expect any change in maintenance factors? Again, work stressors. Do you expect any treatment for, say a patient presents with a back injury and then depression as a result of that? Is there an expected treatment that the patient is going to be undergoing in the next few months, which may change their physical impairment and their psychiatric impairment? So you need to try and assess for those factors: alcohol misuse, use of opiate-based medications, analgesic medications that can cause significant psychiatric symptoms. Some variability is generally acceptable. If you provide a rating, an impairment rating for somebody, say 15% WPI impairment rating, a 10% variability over there is acceptable. So 13.5 to 16.5 as such. And you can't always accurately predict the impairment because you're predicting the future. So variability, a very small variability, is acceptable. It's okay. All right, so I'll just give you a case example to demonstrate those three factors, and I'll give you a situation and you can tell me if you think this person is fit to be assessed for permanent impairment, if this person meets maximal medical improvement. So a 25-year-old lady who has suffered with an adjustment disorder, and it has deemed to be work-related, and she suffered it for a period of 3 years, and she's had active symptoms for a period of 3 years. She has received antidepressant treatment. She has received psychological treatment. She's recently been referred to a psychiatrist as well, and she's seeing all of them regularly. She's had a recent hospital admission. She presented with suicidal ideation. She didn't really do. She wasn't really doing very well, so she had suicidal ideation, and she saw a psychiatrist who admitted her into hospital. And she's now back. She's been back for a couple of months, and she's come in for a permanent impairment assessment. Would you say that this person reaches the criteria for maximal medical improvement?
No.
And that's because?
She's only just been in hospital 2 months prior, so I take it from a year from that point. Is that what you do?
Yeah, so which one of those three pillars is probably not in place over there?
Stability.
Yeah, so 3 years, you can say it's reasonably permanent. Antidepressant, psychiatrist, and CBT, she's received quite a lot of treatment, but she's had a recent hospital admission, and that changes things. She's not had consistent symptoms. So if you assess her at this point, two things might happen. You might give her too high a rating, because of the recent hospital admission and her symptoms. You might actually give her too low a rating because you'd say, well, you can't keep the hospital admission can't take the hospital admission into account because it's been a recent one. Let's look at how she's been over the last 3 years. That tends to happen as well. So you can give her a low rating as well. So things may not work either way, and it's not appropriate in such situations to give an impairment assessment and say this is what the permanent impairment is. So she's not reached the stage of maximal medical improvement. Right. I'm going to talk to you about 3 or 4 impairment rating scales and give you an idea. Now, I'm not breaching any protocols or privacy policies here. What I'm telling you is freely available on the internet. The first one and the most common one is the psychiatric impairment rating scale. It's been around for the last 13 years, also known as the PIRS or the PIRS. The second one is the Guides to the Evaluation of Permanent Impairment, edition 2.1, commonly used by ComCare, Department of Veteran Affairs, and some other organizations. The third one, Global Assessment of Functioning, or the GAF score. I'll come to speaking about each of these. And then the AMA Guides, the 4th, 5th, and 6th edition. We tend to use all 3 here in Queensland. Right. The first one is the Psychiatric Impairment Rating Scale. This is probably the most commonly used one, and any assessments that you will see will more than likely include this assessment. So please remember, it's a Psychiatric Impairment Rating Scale, not the Permanent Impairment Rating Scale. It often gets confused in terms of, actually, in the whole of the scale, there is no mention of the word permanent in the whole of the scale. We still use it for permanent impairment. The scale asks raters to give ratings across 6 domains. Those domains are your cognition, your travel capabilities, your work capabilities, your social interactions, your relationships, your self-care and hygiene. And then you kind of put them together, take the median number, sum it all up, put it into a table, and you get a rating. It's reasonably simple, to be honest. It's not difficult. The GP guidelines, the GEPI guidelines as such, with work cover that are going to come into place now or have come into place now, uses the AMA guidelines except for psychiatric injury, where the Psychiatric Impairment Rating Scale is used. The advantages: it's relatively easy to do. Once you get a hang of how it is, it's relatively easy and quick to do. But you need to know how it is done. Once you go through that, it's relatively easy. It has been tried and tested over the last 13 years and across several fields, and it works reasonably okay. It takes into account treatment factors, what treatment the person has received, or what effects the treatment have had. So if there is improvement with treatment, the impairment rating may be slightly higher, so they give allowances for that. It looks at work functioning. How the person is functioning at work, which I think is quite important. The disadvantages of the PIRS: it's not a very well validated rating system. It hasn't been validated very well. There have been tests that have been conducted, and the validity of it is not very good. It has variability. If you have 3 different psychiatrists assess the same person on the same day and do a PIRS, I've got variability of 20%. We once had an assessment where 3 of us as examiners sat in together, saw the same patient. At the end of that, we just kind of said, look, why don't we just put down our impairment ratings on a piece of paper and see how this much differs. There was a difference of 20% across the least and the highest. For the same patient, the same time, the same questions, 20%. The descriptors of each of this class, I said you got to rate these people on 1, 2, 3, 4, 5 on each of these domains, and the descriptors are quite vague. They're not very easy to say, yes, this person easily meets this point and this impairment rating as such. It's not easy. It ignores risks. It doesn't take into account any risk that the patient has, not at all. Right. The second one is the guide, or the Guide to the Evaluation of Degree of Permanent Impairment, assessment of degree of permanent impairment, commonly used by ComCare, also used by DVA as well at certain points. So it's a different system. It's quite a different system than the Psychiatric Impairment Rating Scale. It relies on the activities of daily living. ADL is activities of daily living. It relies on requirement for treatment. What is your requirement for treatment if you suffer with a psychiatric condition? And it relies on your risks. So, is it medium risk, high risk, and therefore the impairment rating changes. Very much reliance on activities of daily living, I have to say that. So the advantages are, from my perspective, it gives a fair bit of significance to the activities of daily living. It gives a fair bit of significance to risks, and it looks at treatment requirements. If a person has been admitted into hospital and required hospital treatment, it changes ratings. Anything that's more than X percentage in terms of your impairment requires you to have support in activities of daily living, and we tend to assess that. The problems, however, is that there's quite vague criteria. So, for example, they say that if you need to have a permanent impairment rating of X% or more, you need to have some supervision and direction in activities of daily living. I underline some, because it's not easy as to what meets some. If a person requires the presence of his or her partner to be present on most occasions when they go grocery shopping because they get anxious, is that some? If the person requires assistance 1 in 5 times when they go grocery shopping, is that some? Or 1 in 10 times, is that some? Where does the line get drawn? It's not very easy to do those assessments. When you actually look into the details of what they define supervision and direction, it makes it a little bit easier. But overall, a slightly complex system, but I think that actually works very well. It is a validated rating. There is variability, again, a significant inter-rater variability. If you have 3 psychiatrists assessing, it'll be similar to the psychiatric impairment rating scale where you get different ratings. That hasn't been tested by me. Okay, the Global Assessment of Functioning, the GAF score. You may have heard of the GAF score. It's part of the DSM. The DSM multi-axial diagnosis, axis 1, 2, 3, 4, 5. Axis 5 is GAF score. Ideally, when you receive your reports and you get a multi-axial rating, if you've asked for a multi-axial rating, you should get a GAF score in the end, which actually is a very good descriptor of how well the patient is functioning, how well the disability is. The GAF score is, as I said, part of the DSM. It's used quite extensively in the USA, and it's simplistic. It assesses functioning across various modalities, your social, occupational functioning, and it includes risks. Just worried something else might fall down. The disadvantages is that the GAF score gives variation of ratings, a range of scores. So this person's GAF score is 61 to 70. That doesn't really help when you're giving permanent impairment ratings. The GAF score doesn't rely as much on activities of daily living. The AMA guides, we've got the 4th, the 5th, and the 6th edition, and all of them are used depending on where you use them. The 4th and the 5th edition are very similar. They're used extensively across the US. They rate the person's impairment across 4 modalities: the activities of daily living, their social functioning, their cognition, their concentration, and finally their adaptability, which is the work capabilities. Extensive use worldwide. They're simplistic. You can combine physical and psychiatric impairments. There are good ways of combining physical and psychiatric impairments. So in that instance, it's very good, especially for people that have physical and psychiatric injury. The disadvantages is that there's massive inter-rater variability. Sorry, that's variability. So there's no table that you look at. You don't go left, right, and you meet somewhere and say that is the permanent impairment. You just estimate it. So if it is mild, it's anywhere between 5 and 15%. If it's moderate, it's anywhere between 20 and 40%. And it basically is dependent on the assessor to estimate that impairment. There are no clear guidelines. They just say, do you think it's mild, moderate, or severe? If it's moderate, just give a rating between 20 and 40%. I'm just exaggerating it, but it is quite variable. It doesn't rely on risk assessment. Even if a person is suicidal or has been suicidal, that wouldn't change the risk assessment. Now, this is what I like. The AMA Guides 6th edition. It's the recent introduction or the recent edition of the AMA Guides. And the reason I like it is because it combines 3 different scales, 3 different rating systems, which include the PERS, the Psychiatric Impairment Rating Scale, the GAF that we talked about, part of the DSM, and there's another scale, the BPRS. And 2 of them are based on the DSM, which we generally tend to use.
The advantages, it's extensively used, and it is an extensive assessment system. It relies on multiple rating systems. So even if there's variability across individual systems, the whole combination, there's hardly any variability. If 3 different psychiatrists assess the same person on same days, you're unlikely to get a different rating. The difference will probably be 1% or something. It's very easy to combine impairments, physical and psychiatric condition. It is time consuming because it takes 3 scales. It can be time consuming. So a permanent impairment assessment, when we get asked for that, generally we first look at history. We focus on the last 12 months. We look at consistency in symptoms. How long have their current symptoms been consistent? Have there been any complicating factors, maintaining factors? Are there any pre-existing issues? If they are pre-existing, you tend to attribute a percentage depending on how bad the pre-existing condition was. What is the treatment that they have received? What is the frequency of that treatment? What is the effect on the activities of daily living? And depending on what impairment rating you use, you ask for risks. Some of them do not rely on risks, some of them do. We have some people over here who have insurance representation, and just quickly covering permanent work disability because of an impairment. Just to let you know, it is situation specific. It changes for every person. And the factors, you always look at balance of probabilities, again, saying that this person is permanently impaired from doing so and so job. Again, you look at severity of symptoms, you look at deterioration, you look at duration. You tend to look at personality factors. Is it their illness, or is it them that do not want to do that particular job? I'm going to run through this because that's not the focus of this presentation. Are there motivational factors involved? What treatment they have received, what treatment is available, whether they are compliant with treatment. And you look at factors in their job. What is it that actually is causing them stress or inability to return to work? That doesn't apply for total disability, obviously. Okay, the last, I think, 4 slides relate to common errors in psychiatric permanent impairment assessments. And these are errors that I have seen, and I can provide you several examples of each of them as well. Some of those errors probably are close to ones that I've made as well. So treatment errors do tend to happen. You can avoid them, but it's not always very easy. The first is treatment bias. I'm sure you'll understand that if a person is treated by their GP or psychiatrist, and if you ask their GP or psychiatrist to give them an impairment rating, it's likely to be higher than what it could be, or what an independent assessor would provide. And that often tends to happen. I've had quite a few situations where the GPs have been asked for permanent impairment rating, and the GPs would say at least 50% because this person is quite severely disabled. But they haven't really had a look at any impairment rating systems. They just believe it's 50% because they see the person as being quite disabled. But they haven't seen this, the rating system. They don't know if it could be 70% or it could be 20%. Mental health providers as well, psychologists, psychiatrists. I often see psychologists providing permanent impairment ratings, and their ratings do not agree with any of the rating system. Even psychiatrists, I have to tell you again, we don't get training in rating PIRS in AMA guides and so forth. So if you ask a psychiatrist for ratings, please make sure they understand the ratings, they understand the rating system, and they're comfortable with the use of rating systems. If they're not, you may get an erroneous rating, which may be too low, it may be too high. Referral bias. Again, you can avoid it, but it's quite difficult. Examinations for the plaintiff lawyers, you ignore past history. I'm not going to name anybody, but I'm aware of, I've seen three reports at least now from a particular psychiatrist assessing patients, for the plaintiff lawyers, and completely ignoring past history. In one situation, the person had an extensive past history with ECT, hospital admissions, and this was like 2 months before the injury. And in the report, in the past history section, nothing significant. Yeah, and Yeah, it's difficult to understand that. It's difficult to understand because anybody sees this person, and I actually asked this person, look, can I confirm that there is no past history of psychiatric illness? I'm like, what? No, I have a big past history of psychiatric illness, and we discussed it with Dr. X as well. But we figured out that, look, it is important, but it still doesn't take away the impairment that I have because of the work injury. So there was a massive variability. So what was an impairment rating of 34% came down to an impairment rating of 3%. The other side is also true. Examination for the defendant lawyers attributes all impairment as pre-existing or related to personality factors. So talk about this person has a work-related injury but had a pre-existing illness, and therefore all the impairment is related to the pre-existing illness. Not in situations understanding that the person was impaired but never had a disability. They still continued to work, they still continued to have a relationship and have social functions until X event happened. Premature impairment calculations, and I've talked about that, the 1 year general time frame. Quite often you have impairment rating provided soon after the event or soon after the injury. The PIRS that we tend to use is, shall I say, particularly notorious in terms of this, because quite often, or in some situations, I've had raters saying, look, this is a psychiatric impairment rating scale. It's not a permanent impairment rating scale, so I don't need to wait for 1 year. I can rate this person straight away and right here. But then that goes for a permanent impairment assessment. Impairment rating provided when there has been little treatment. Often there have been situations when there have been limited treatment, has been limited treatment provided, or before stability. We have talked about that. A particular situation applies to those that suffer with PTSD, post-traumatic stress disorder, because they can have commencement of symptoms years after the initial event. So that's a complicating factor. You could assess them a year after the event and say, well, it's 1 year that's passed, and let's rate this person. But they could actually have a lot worse symptoms coming up later on. PTSD can present in a delayed form, particularly with war veterans and so forth. So it is a complicating aspect, and that needs special consideration. Again, in children, I recently assessed I think it was an 11 or 12-year-old boy who was involved in a fairly traumatic accident, and I assessed the fellow about 6-7 months later. And he was fine. He was absolutely fine, and he was functioning extremely well. But there were certain aspects of his presentation that said that he probably was not all fine, and that things may change once he becomes an adult, once he has responsibilities, once he has to go and work. At this stage, he just has to do his usual 12-year-old thing, which is probably not as difficult as an adult life. I'm sure you'd agree with that. Sometimes it is. But but situations in children is different, and assessing permanent impairment in children requires a lot of consideration to what might happen in the future. I think it's the last one, second last one, duplication. A 30-year-old gentleman with work-related back injury and a secondary depressive condition. He's on high-dose analgesics, painkillers for treatment. He talks about a reduction in functioning, a serious reduction in functioning due to back injury. He's not able to complete his activities of daily living due to his physical condition. He cannot shower himself, or he cannot brush himself, or he can't wear his suit and so forth because of physical condition. He talks about because the pain is there, it doesn't allow him to sleep. Because of his high-dose analgesics, his concentration is not very good. He's quite doped up. And because of his pain, he doesn't like to go out much. He doesn't socialize as much. His motivation is very poor. And this person received an impairment of 17% for back injury and 15% for psychiatric injury, and was sent across to myself for an assessment again. And what I found out with this person was that he had a serious back injury. There's no doubt he was in pain. He was in pain during the assessment, and it was very obvious. as well. His disturbance in sleep was because of his pain. He said when he isn't in pain, he would sleep extremely well. His concentration issues were because of his medications, the analgesic medications. And when he wasn't on that high doses, his concentration was reasonably good. His socialization, again, he wants to go out. He wants to get outside. He wants to meet people. But because of his back injury and the requirements as a result of that, he sometimes needs to use a walker and so forth. He doesn't feel like going out, but he wants to do that. So effectively what I'm trying to say is quite often you have psychiatric sounding symptoms, but they're actually caused due to physical injury. Over here, sleep, concentration, socialization. All these are not because of the depression. They're because of the physical injury. And if the person didn't have the physical injury, they would not have these disturbances. And such situations, what tends to happen is they get rated for impairment for their back, including those sleep, concentration, socialization issues, and then they get rated for psychiatric injury, including those sleep, concentration, because obviously they don't have concentration. It tends to get ignored that the concentration lack is because of X factor, because of the physical injury. Now the other thing is true as well. There kind of is a trend of passing the parcel between psychiatrists and orthopedic surgeons, and that particularly happens when there is a pain condition. And the surgeons are not able to give an adequate physical explanation. There is no physical condition that explains this person's pain. So let's have a psychiatric assessment. And the psychiatrists see the patients and they say, well, there's no psychiatric reason for this person's pain. There needs to be an orthopedic assessment, and any impairment is as a result of orthopedic issues. I've had a situation where something like this happened, and a person presented with chronic pain after a fairly severe injury, and after 2 years I was assessing permanent impairment, and the orthopedic surgeons basically said that, look, this person does not present with any level of impairment. The reason being it's either pre-existing or because there's no physical cause. You know, I can't see anything on the radiological investigations. I can't see any other reason why this person may have a physical component to the injury. And then when I assessed the person, there's some other psychiatrists that assessed the person and said there's no psychiatric injury, he's depressed, but you can't really rate the pain based on psychiatric condition. So effectively this person was going to get a 0% impairment, I guess. But then what was ignored across the two assessments is that the patient had an injury, the patient had pain, and the pain has been present since the injury. And with the duration of pain, it's likely to continue. We often tend to have a poor understanding of chronic pain, and we often tend to have a poor understanding that pain can sometimes have psychiatric origins. There are diagnoses in the DSM system, somatic symptom disorder, pain disorder, where you can rate pain conditions without a physical causatory relationship to psychiatric condition. As long as you're still able to demonstrate the relationship to the injury, you can then give them an impairment rating as well. And quite often they go across both the assessments and nothing comes through, which gets lost. The last slide. After somebody is given a permanent impairment rating, the symptoms of the disability generally improves. I'm not kidding. There was a study that was done in the US for war veterans. There was a study done in the US for war veterans. They actually followed up 200 war veterans that had psychiatric symptoms and that had claimed that they were not able to work because of their psychiatric symptoms. 200 of them. And they followed them up until their claim was finalized. After their claim was finalized, in the first 6 months, 180 of them returned to work. You can't really change that. We all have a sense of abnormal illness behavior in us. In that when we go for assessments, things do change. It's not that you're faking it or so forth. It's just that it tends to happen. When a person after permanent impairment has an aggravation, we apply similar principles, take that as a pre-existing condition, and go through the assessment as usual. I talked about delayed symptoms and PTSD in children, that requires special consideration. And that's it. Thank you. So the question is if somebody has a previous diagnosis of PTSD and you've gone down several years down the track, and because of that PTSD, if there is a risk of further aggravation several years down. There are two factors over there. One is that this person is not what we described as the delayed PTSD. He's already had symptoms, he's already had the assessment. So once you've had the assessment and once you've had the symptoms and impairment, that generally, if it tends to settle down and if they're doing well, it's unlikely that this person will then have recurrences. You may have triggers, but those when you do an assessment, say 2 years later, should keep into account that this person could have aggravations on a day-to-day basis. So if a person cannot start having, or can, but in general situations, they don't start having aggravations 10 years later. It does tend to happen, but the question that needs to be asked is that a new injury, or is that a new injury based on a background injury that has occurred? Quite often you get work situations where a person has PTSD from other events and then has PTSD from, or has PTSD symptoms. So I think my answer to your question would be that there is a possibility, but when the person has the first assessment, it should be kept into consideration that this person could have aggravations through day-to-day stressors. I don't know if I answered your question.
I guess it's more like
PTSD in psychiatric conditions has the worst prognosis. There's no doubt about it. It's the worst condition to have. If you had to pick one condition, don't pick PTSD. They did a study of PTSD patients and a 7-year follow-up of those patients that received treatment and those patients that didn't receive treatment. And the curve kind of went up and then came down and reached at the same point. So eventual outcome with or without treatment is the same. To answer your question, I don't see a reason why they cannot go back to work because yes, they have PTSD and yes, they have a risk of aggravation, but that in itself shouldn't be reason enough for them to not go back to work. The same applies for situations where patients have suffered with depression or anxiety disorder and have not stopped working and now want to get back to work because they're feeling well. They still have a risk of aggravation or still have a risk of recurrence. But as long as the risk is not significant to themselves and to anybody else around them, I think it's okay for them to go back. Again, you look at the length of symptoms, length of time that they've been free of symptoms, or how they're focusing, if there are other maintaining factors that are involved. So I think they can go back, yes. What do you think the impairment would be if they undertook that treatment is not an easy question to answer, because not everybody responds to treatment. And my taking on that is that if a person presents with absolutely acute symptoms and is really impaired, they need to seek treatment. But they are, they have the capacity to decline treatment that is offered to them. When we look at medical or ethical principles in medicine, one of the principles is autonomy. The person should be allowed to take decisions regarding their treatment. And if they decline treatment, there's not much you can do, because say a situation where I had a situation actually where a person had 3 different impairment assessments 1 year apart, and the person was simply declining treatment, and the same psychiatrist said, look, this person cannot receive an impairment rating unless and until they receive treatment with medications. And I think he recommended ECT, but medications was the important thing. And this the claimant did not want medications. She was against medications. She felt that she did not want an external drug to influence her system and cause that. It didn't really make sense, but it was still the person's decision. There are people out there that just don't want treatment. If this person would have refused all intervention, psychiatric, seeing a psychologist, seeing their GP, I probably would have said, no, they're not fit to be assessed for permanent impairment, because they need to seek some treatment. And when they say they're okay to receive this treatment but not this treatment, I see, as long as they've got a good explanation for that, for why, that's reasonable.
your evidence.
Yes, but but if you still look at a medical assessment, it asks autonomy from the patient. So whilst there's a recommendation that this person receive treatment, it's not a necessity that this person receives so and so treatment, because you'd get recommendations saying start this person on X or Y medication. You know, the person might go back to the GP or the psychiatrist and they might say, no, we'll try something else. Yeah, we'll try something else. So I understand what you're trying to get at, but what I'm trying to tell you is that eventually there will be a point where something has to happen. So if the patient does not receive treatment and you assess them 10 years down the line and they're still claiming for impairment, they still not want treatment, something has to happen. In that situation, depending on which, who you're assessing them for, you could. I've had situations where I've said the current impairment rating is 12%. I believe that with treatment, this impairment rating could be reduced to 8%. But that is conjecture. That isn't an assessment. I've done that at times, but I'll tell you, it's not easy to then say that, because that impairment rating could come down to 0% or could stay at 12%. So you can give an estimate, but it's only an estimate. I'd still say if it has been, say, approximately 1 year and the patient doesn't want to receive treatment, I'd ask the patient, look, okay, I understand you don't want to receive treatment. Or not that I understand, but can you explain to me why you don't want to receive treatment?
They say to you, I'll never take medication, it goes against my original for whatever
Yeah,
reason.
yeah.
So
I'd ask them if they'd receive alternative intervention. I'd ask them if they'd see a psychologist. I'd ask them if they attend groups or programs or so forth.
Yep, so say they tick those boxes,
Yeah.
a psychologist or a psychiatrist, but
Yeah.
refuse to take medication only
Yeah.
after 1 year, how would you rate that one?
I'd still rate them for permanent impairment. If their conditions, if their symptoms have been stable, or if the other things are met, I'd still rate them permanent impairment if asked to do so. As asked, I'll make a note that, but I don't think that note does anything.
Yeah.
That note that the person is refusing treatment is just to document things. It doesn't change anything for that. No, there isn't any literature. I was actually looking up on that a while back, because it's not easy. As a psychiatrist myself, practicing, I get requests for reports and ratings and duration of work disability, and you tend to get worried, at times, if you're doing the right thing. But all you can do is try to give the most transparent rating. I had situations where I've seen at least, I think, 2 patients for independent medical examinations, and I've said this person requires treatment and so forth, and they've come around a couple of months later to my clinic saying they want to be treated by me, and I've told them it's not appropriate because I've seen you for an independent examination, and they've come around and said, how long is it inappropriate for? So I said, 12 months is what I hear. And actually, 2 of them come back in 12 months. And they say, can you treat me now? I said, yes, I can treat you now, but I'll just need to write to the workers' compensation organization and say, look, I cannot give you any more independent assessments because I'm treating this person.
And you can't go to court.
No, I can't. After that, I can't. So, but I'll let the assessor know that, look, it's no longer an independent opinion. If you ask me for an opinion, it's going to be a treater's opinion. Fill the gaps. Yeah, but then what is a medical legal report? I mean, quite often you get reports that are not actually medical legal in nature. They just simply include assessments or clinical opinions that you have. And I think that's reasonable. So if I get a request for a patient I'm treating for impairment assessments, I'd say this is my assessment, but you seriously need to see an independent psychiatrist for that. All right. That's probably it, I think.
All right. Thank you, Dr. Shaikh. I'm sure there's some, a lot of questions coming out of people. If you don't want, I know some people don't like to get up in front of the crowd and actually ask the question, but maybe if you want to talk to Dr. Shaikh after, I'm sure he'll be hanging around for another 5 or 10 minutes as well. So thanks very much for everybody coming along, and I'd also like to thank Dr. Shaikh for his presentation.